Hey you guys, welcome back to another video. My name is Shania. If you are new to my channel, right now I am working and I thought, why not, keep this streak going? I have to sit here and work for 8 hours, so why not just give you guys something today? Because I do want to switch it up here and there and, get back to my book reviews, my regular vlogs and all that. But before my day is over, I want to record me coding a note, and then I also want to give you guys some tips for my OBGYN coders. Have you guys heard of ACOG? It is the American College of Obstetrics and Gynecology. Do you guys know you can go onto their website and sign up to basically be a subscriber of theirs, and they have coding tips on there, coding solutions. You can submit tickets. I think it's 3 tickets every 30 days. I'm not sure, but what the ticket is, you can, copy your operative note that you're reviewing, and you may not be sure like what code to use. It doesn't even have to be an operative note. It could be like an office note. You're not sure of what excision code to use, or what other ones do we struggle with? Like those skin tags. You don't know what code to use for that, depending on the technique they used. You can copy your note into a ticket and submit it to them, and then they will get back to you within a week with the response on the code that they think you should use. Maybe you're struggling if you should use a modifier 22 or if you should bill it as is. The website is acog.freshdesk.com/support/login, or it could be acogcoding.freshdesk.com/support/home. So try that. I will have it in the description box for those of you that are interested. But yes, I totally forgot to share that with you guys. I use it not often because, like I said, some of the information in the notes and stuff that I review is kind of repetitive, so I know. But there are some notes that can be a little bit tricky. Let me go into my emails to see one that I might have had a question about, just to give you guys an example. So I just said here, I said, I'm looking for guidance on an office procedure for a vulva biopsy. If the provider is using forceps and or scissors to remove the sample, would I report the 56605? If this had required a suture, would I report 11400 instead? And then I pasted my documentation in there. They came back to me and they said CPT code 56605 does not specify the method by which the biopsy is performed or obtained. Therefore, it would be accurate to report CPT code 56605 if the biopsy was obtained with either forceps and or scissors. The use of sutures to repair any defect associated with obtaining the biopsy would be included as part of 56605. In the case example associated with CPT code 56605, the ACOG 2023 OBGYN coding manual states simple suturing may be required. Therefore, the use of CPT code 11400 would not be appropriate. There you have it. I asked the question, they came back with me, told me what code to use. So definitely check them out. It's free also for you to sign up. And again, they only give you, I think, like 3 tickets per 30 days. I think that's what it is. So yeah, check it out in case you guys would like to use it. But for right now, I am looking at a inpatient hospital surgery, and I am going to be billing a total abdominal hysterectomy for a patient with a uterine leiomyoma, which is also a fibroid. This is going to be an open procedure, and I know that it's open because of the type of incision they are making, and it is the Fannin Steel skin incision. Was made 2 centimeters above the pubic symphysis. This was made with a scalpel. Fascia was excised in the midline using a scalpel. The peritoneum identified and entered bluntly. The peritoneal incision was then extended superiorly and inferiorly. The uterus was markedly evident upon entering the peritoneal cavity. A hand was inserted into the abdomen. The uterus was noted to be clear of adhesions. The uterus was then exteriorized and noted to have the findings as below. The anterior leaf of the broad ligament was dissected to the level of the uterine arteries. The same was performed on the left side with the aid of the ligashore. The uterine ovarian vessels bilaterally were then isolated through the vascular window created from taking down the round ligaments. The uterine ovarian vessels bilaterally were ligated and divided with the ligashore. The broad ligament was divided using the ligashore to the level of the uterine arteries. At this time, the attention was then turned to the visceral uterine peritoneum, which was tented up with pickups, and bladder flap was then created sharply with medicine ball scissors. Then the bladder was bluntly dissected off the underlying cervix with the moist Ray Tech sponge down to the level of the cervix. So they already dissected all the uterine arteries to be able to remove the uterus from the pelvic wall, floor, all that stuff. At this point, the uterus was pulled on traction and the uterosacral ligaments were easily visualized. The ureters were identified on each side. So sometimes as they are doing this procedure, they will see the ureters, and it is so important that they do not cause any injury to them, because then they may have to have a urologist come to repair the ureters. So they identified those on each side. The uterine arteries were then ligated and divided using the ligashore. Continuing along the side of the cervix, the ligashore was used to transect the cervix from its attachments until the cervical vaginal junction was reached. 2 curved clamps were placed on each side of the cervix, the points meeting in the middle, and the uterus and cervix was amputated from the vagina using curved Mayo scissors. The cuff was then grasped at the center of the Coker clamps. And my coworker had always told me, whenever you see the cuff was closed, this means the uterus and the cervix is no longer attached to the vagina. The cuff is the vaginal cuff. So the top part of your vagina, or the end point of your vagina where the vagina and the cervix meet, now they are closing the vagina. So that is the cuff. And it says here, the cuff was closed with multiple figure 8 stitches using a 0 vicryl suture pop-offs, making sure to incorporate the posterior peritoneum in the closure. Now we have the abdomen was then once again copiously irrigated with warm water. Every time I read that part, I just get so happy because 1, the procedure is over. 2, I can visualize it because I've watched so many laparoscopic and maybe some open procedures here on YouTube. And they're basically just clearing it out, rinsing everything out, making sure it's nice and clean. All areas were noted to be hemostatic. And it says the retractor was removed. We then proceeded with a cystoscopy. So right now they're taking up a scope up through the bladder to make sure there were no injuries. If there were an injury, again, they may have to have a urologist come to fix the injury. Our providers would not bill for the repair if they caused the injury. It says here, bilateral ureteral jets were noted and bladder survey was normal. The Foley was replaced, the fascia was closed, the subcutaneous tissue was noted to be hemostatic, the skin was closed with a 4-0 monocrol in a subcutaneous fashion. The patient tolerated the procedure well, the sponge lap and needles counts were corrected. The patient was woken and from anesthesia and taken to PACU in good condition. So our operative note is over. I will just sit here and review some of these findings. And then again, we have our specimens that were sent, which are the uterus and the bilateral fallopian tubes. So I'm gonna go check pathology really quickly to see if we have any other diagnosis other than what was our post-op diagnosis. And again, they have the leiomyomas, so that is the D25.9. I'm gonna keep that. And it looks like the right and left fallopian tubes, there were no diagnosis for those. So the weight of our uterus, because of the code we are billing, I would say you don't need to worry about the weight of the uterus unless it was like significantly large and maybe it took the surgeon a significant amount of time to remove the uterus, but they have to have that documented. So for right now, our code we're going to be looking at is the 58150. Let me see here. Select coder says it is the total abdominal hysterectomy, corpus and cervix, meaning the uterus and the cervix, with or without the removal of tubes, with or without the removal of ovaries. So whether they remove these tubes or not, this is our code that we are going to bill, the 58150. And let me see here, because we have one more day in the hospital for post-op, and that is going to be the 99024. And my diagnosis code for that, I'm going to use the Z90.710, which is the acquired absence of both cervix and uterus, as well as Z90.79, which is the absence of the genital organs, because there is no code for bilateral, salpingectomies, or the absence of both fallopian tubes. They do have a code Z9722 for both ovaries, but they did not take the ovaries from this patient. So that is it. That's all I have for today. So thank you all for watching, and I'll see you all in my next one. Bye.